I'm Juan González Moreno. I'm an internal medicine physician working here in Palma de Mallorca in Hospital Universitario Son Llàtzer. And me with Dra. Losada and Dra. Eugenia Cisneros, we coordinate the multidisciplinary unit in ATTR amyloidosis. As we live in an endemic focus of ATTR amyloidosis, we attend mainly this kind of population instead of other kind of amyloidosis such as AL or wild-type amyloidosis. Our patients here are mainly Val-30met, the most frequent variant of the TTR protein, and it's almost related with a polyneuropathy phenotype, especially when it begins before the age of 50 years old. We have a mean disease onset of 47 years old, so we have either early onset patients and late onset patients, mainly neuropathic disease, but also when they start the disease in an older age, we see also cardiomyopathy related to the disease. We have other mutations, we have also wild-type amyloidosis and AL amyloidosis, but our main work here is with Val-30met variant TTR amyloidosis.
My name is Eugenia Cisneros. I work here at the Hospital Universitario Son Llàtzer since 2015. The multidisciplinary research unit of TTR amyloidosis here at our hospital started in 2012. It was a nice story of growth because my former boss realized that he was seeing at the outpatients consultations a lot of patients of the variant type of transthyretin amyloidosis. By that time, we did not have any treatment available here at the hospital, so he did his research and found that they were developing several drugs for this disease. So he decided to inform the companies who were developing these drugs that we got patients here and that we needed to get involved in these clinical trials in order to get these drugs early for those patients. So thanks to that and the management of the trials, he was able to create a solid multidisciplinary team which involved neurologists, cardiologists, ophthalmologists, and the internal medicine specialist. And then we grow and include another medical specializations here also at the hospital, and we started our own research.
I'm Inés Losada. I'm an internal medicine physician and I'm one of the coordinators of the multidisciplinary unit in ATTRv here in the hospital. We have here in the hospital a multidisciplinary unit for the management of patients with ATTR. In this unit we have a lot of specialties included, like cardiology, neurology and internal medicine are the main specialties involved, and we also have nephrology, hepatologists for liver transplanted patients, and these are the main, and genetician in the hospital here near our hospital. And then if we need help from other specialties, we can talk with them and manage together these patients. The multidisciplinary unit in our hospital is coordinated by internal medicine. So when a patient is sent to our unit, it's visited first by internal medicine doctors, and after it, if we consider, it's sent to cardiology and neurology if it's necessary.
As we work in an endemic focus, we study all the families we're carrying the variant. So the main way we diagnose patients is by asymptomatic carrier follow-up. We know all the individuals when they carry the mutations before having symptoms, so we follow up them frequently, almost every year, to diagnose if the disease has started. Other ways, we also have new cases, new families, and they attend by neurology department, cardiology department, or internal medicine department are the main departments we attend these patients.
Regarding the diagnostic tools, it depends on the phenotype of the patient. We are in an endemic focus of a neurological variant of the disease. And for the neurological follow-up, we do have a fully complete, I would say, a battery of tests. We do have, obviously, the regular electromyography available here at our center. In fact, that's really important also. In our community, in this center, we do have 2 neurophysiologists. That's not quite common because usually in other centers, this kind of test is done by neurologists. But here in our center, we do have 2 neurophysiologists. Then they also have available several small nerve fever diagnosis tools. That's also really uncommon. Not all the centers have available this kind of tools, and this kind of tools allows us to diagnose the disease early, which is really important in order to avoid the unreplaceable damage that is caused by the disease. We do have the pseudoscan, which is a non-invasive technique, really fast. This is available at the outpatients consultancy, so every time that the patients come here at the hospital to see, in this case, the internal medicine doctors, he can be tested by pseudoscan. It takes just a couple of minutes, so that's really helpful to direct the diagnosis of the patients and to follow up those patients. And then by the neurophysiologists, we have the sympathetic cutaneous research response test. Then we have also proof to test the sensitivity to heat and cold. And then we have also another tool to investigate the breath ratio compared with the heart ratio. So for the cardiac phenotype, we do have here on site the echocardiogram and the magnetic cardiac resonance here on site. And we have access to the gammography at the reference hospital. And then I have also mentioned that we have a full team of other specialties available for those patients depending on the phenotype and the manifestation that they show. We do have a full genetic service, but in the reference hospital. We are here in a small hospital, so some of the tests that are more specific are only available at the reference center, but we do have fully access to that. So the genetic testing, despite the samples are collected here, we have to send it through internal mechanisms, so nobody realizes. In fact, we have to send it to the genetic facilities, which are in the other hospital.
Nowadays, in Spain, for the treatment of the neuropathic symptoms of the disease, we have 4 treatments available. One of it is a stabilizer, and the 3 others are a transthyretin silencer. So how can we decide which treatment is the most appropriate treatment for the patient? If the patient is in a very initial stage of the disease, of the neuropathic disease, we can start with a stabilizer. That's what we decided here in the Balearic Island. We start with a stabilizer, and if it does not work, then we can change to a silencer. How can we decide which silencer we offer to the patient? This we decided in a multidisciplinary unit, and asking to the patient what he prefers, if he prefers a subcutaneous treatment or an intravenous treatment. This is the neuropathic phenotype, and if we have a cardiopathic phenotype, there we only have one treatment available, is a stabilizer, and it's an oral tablet, and it's the only option we have. And if the patient has a mixed phenotype and an early neuropathic symptoms, we have to give them a stabilizer, and if it's progressed, now we are changing to a stabilizer because it has a neuropathic phenotype also.
Related to the research activities in the amyloidosis research line, we do have a lot of experience, and we do have a lot of projects on mind and ongoing nowadays. On the one hand, we participate in several clinical trials. We try to get involved in all the trials that came for this disease, because this is the way to access the drugs in an early manner, and that's a benefit for the patients. On the other hand, we do have also a leading role in the real-life studies. That's also really important because, as you may know, clinical trials are developed during a short period of time, but we are talking about a chronic disease. So we are in the need of generating data of the real use of these drugs and for long periods of time. So my colleagues also lead real-world studies on the available drugs nowadays. Then, on the other hand, we also have several research projects. We are now entering in the multi-omic era. We are trying to perform an atlas of this disease, a multi-omic atlas of this disease, because we have a really big cohort of subjects here in the island. we are talking about 240 subjects between asymptomatic carriers and patients. So that's quite long for rare disease. So our aim is to create a multi-omic atlas in order to better understand the disease and then develop small projects. That's not all also. We do have a solid relationship with the patient advocacy group here in the island, and that's a good way to start research because they have the opportunity to ask questions that we can turn it in research projects.
Our center, as is one of the main centers in attending ATTR amyloidosis in Europe and also in the world, we are living in one of the largest focus of the disease. We have tight connections with other international centers, such as, for example, Lisbon with Dr. Conceição, or Porto with Dr. Coelho, but also in other centers, such in France with Dr. Villain, Planté-Bordeneuve, or in Italy with Lauro Vici. So yes, we have some kind of relationship either in independent research but also in collaboration with other clinical trials with other international centers. Ophthalmological and central nervous disease symptoms are really invalidating, so we collaborate tight with other research units in order to find new ways to treat this orphan manifestation of the disease. And also we we are starting some projects also to include in our unit psychologists and occupational therapists specialists in order to make this holistic approach that the patients need in a multisystemic disease.
Raising awareness is a tough duty. What we do is we participate in several meetings that are organized by patient advocacy groups. We usually have 2 or 3 meetings per year. They call us in order to explain which are the updates regarding the diagnosis, treatment options about the disease, or the management, even the management. So we meet with them at least 2 or 3 times per year. Then that's really important. We are here in an island, it's quite small and we are all like a family. So how it works that everybody has our phone numbers. So that's also a good way to create awareness because they know, for example, their symptoms, they know if they are worsening or not. We have also create awareness through working with the university. That's also really important because my colleagues and myself, we usually go to the university to teach about the disease. Here we have a truly solid network of dissemination of knowledge created. Then regarding the public authorities, that's really the most difficult part because what we do is we call in order to get meetings to explain what we are doing, but we are aware that we need to invest more efforts in order to get better answers of the authorities. But at least we do have meetings, they hear us, so that's the first step. I think we are in the early stages of dissemination of knowledge through the authorities, but they know. Also, we organize every 2 years the national meeting of the disease, and we have the collaboration of the authorities. In fact, this year, this was the first year that we had the support of the president of our community. So this meeting was on the media, and that's also another way to get disease awareness.
The first challenge when the unit was formed, it was to put all the specialists together and to form the multidisciplinary unit. It's not easy because you have to talk with a lot of specialists and put them all together. And this was the first challenge. And after that, monetary problems because for making the research we need a person, one or two, or it depends on the research you make, and we need a person coordinating this research. So at the beginning we had no money to pay this person, but with more research we finally get money to put a person managing all the research so it can work better.
We are now in the process to find a way to establish a solid unit, a recognized unit by the regional authorities. That's the first step, because we need to make it visible for the authorities what we are doing for this disease in order to get resources. And we haven't reached this point yet. And then regarding the national authorities, I think the answer is more easy because we have another examples. How it works here in Spain is by the designation of reference centers, which are called CESURs. That's the word here in Spain. In order to be designed like a reference center, like a CESUR, you need to apply for and to have several indicators, okay? But first the health ministry has to create the need for a disease and to establish these indicators. For the amyloidosis, the need and these indicators haven't been developed yet. So we are nowadays still in the beginning of the way. I'm aware that the Spanish Rare Diseases Federation, which is called FEDER, has asked to the health ministry to create a need for the amyloidosis in order to be able to designate reference centers. But we don't have an answer yet. We hope that the Spanish Ministry of Health establishes the need within the amyloidosis disease, and then to move on in the development of the indicators to be selected as reference centers. Regarding public policies for the establishment of centers, unfortunately, here in Spain, as far as I know, we do not have any yet. How it works, on the other hand, is by initiative of the centers. That's the way here, at least as far as I know. A center has a team, the team works as a unit, and because there is a solid Spanish medical doctors network regarding the disease, especially because they meet during specific meetings that are developed here at our country. So this makes it easier to informally create reference centers. But as I told you, we don't have yet a book or directions to create these kind of centers.
I think that the main point is to create a good group interested in the disease, especially with the three main specialists, cardiology, neurology and internal medicine. Our experience working in a multidisciplinary unit has been excellent, so my biggest advice would be to work in this way, not just in amyloidosis but also in other multisystemic diseases, as it's very worth it, not just for patients but also for the physicians, because we can learn a lot from each other.
My advice to the healthcare providers that want to establish an amyloidosis center would be that it's really easy to find the contacts of people who has already established one reference center. So maybe doing a short internship or just talking to them can really help them to start, because the starts are always tough. Especially I had the experience here because I'm here since the beginning, and talking and visiting our centers helped us really much to create our unit here.
If you want to create a multidisciplinary unit, you just need to have vision. If you want to create it, keep on working in it and you will get it.